So the topic is the patients who are on dual antiplatelet therapy and what to do about the thrombolysis in this group of patients. Now we have already heard about that dual antiplatelet therapy in a form of setting where patients have a minor stroke or TIA from Professor Prasad. But this is a situation because many patients of, as you have seen, that many patients of stroke will always be having some other concomitant atherosclerotic process involving the cardiovascular system or peripheral vascular system or even the gastrointestinal vasculature, and they will be on antiplatelets. So if they are taking antiplatelets and then they develop the stroke, what to do about them, how to go about that. So first of all, I would like to say about this guideline which is there from 2018 and which has suggested that the prior antiplatelet therapy, IV alteplase is recommended for patients taking antiplatelet drug monotherapy before the stroke on the basis of evidence that the benefit outweighs the possible small increased risk of significant ICH. So this is a class 1 evidence, and the level is A. So it's a very highly good recommendation. But people who are taking, say, combination therapy, for example, aspirin and clopidogrel before the stroke, there it is class 1 still, but the level of evidence is BNR, means that it is either a small randomized trial which is not powered enough as described by Dr. Kameshwar Prasad, or it is not available, good evidence is still not available. So this is generally the place, this is generally the recommendation. So I can stop here, but just to kind of proceed with how this guidelines came about, I would like to show you some of the data which has been generated over the years. So the safety of the antiplatelet therapy prior to IV thrombolysis was generated soon after the IV thrombolysis became popular, and they have, as has been shown, that the percentage of people getting the IV thrombolysis increased over a period of time. But the real thirst came in about 2008 or so, because in 2003 and 4 there were a few scattered studies, but they were not much. But this was one of the first studies that has shown the safety of antiplatelet therapy prior to intravenous thrombolysis from a Netherlands group. And what they have actually shown is that despite the higher incidence of symptomatic ICH, the net benefit of intravenous TPA for acute ischemic stroke was greater in patients using antiplatelet drugs. So therefore, although there was a risk of hemorrhage, but overall the patients fared better. And that led to basically a kind of an editorial by Werner Hacke way back in 2008, and then they questioned that whether it is safe enough to be beneficial. But they concluded that with the available evidence, even at that time in 2008, there was this widespread use of, increased use of TPA. People who are already taking antiplatelet drugs, it is still justified because overall the patients become better compared to those people who are not thrombolyzed. So this was an important study. Then came 2010, this study in which they showed again the safety of intravenous thrombolysis for acute ischemic stroke in patients receiving the antiplatelet therapy at the stroke onset. And as you can see, that except for this MRS 3, where there is a slight shift towards the group which is getting the antiplatelet agents in terms of the worsening, the rest of the groups are actually faring more or less the same. And they again concluded that although there is an absolute increase in the rate of significant ICH, that is about 1.4%, in the pooled AP group, that did not actually produce the outcome in terms of the results seen over 3 months of period in terms of the MRS that was there. And therefore, the antiplatelet therapy should not be considered a contraindication to thrombolysis. So this was an important and good study. Then came this study by Dorado et al., and which again showed that this is in the European Journal of Neurology, and basically this is from a Spanish group. And they also showed that if you see the level of all parenchymal hemorrhage in the antiplatelet group, it is coming out to be about 18 out of 72, whereas in non-antiplatelet group it is 15 out of 162. So this difference was significant, but if you see the symptomatic ICH and the poor outcome, the difference is not significant. So they again said that the pre-treatment with antiplatelet agent is associated with an increase. Definitely there is an increase in the parenchymal hemorrhage, but really it doesn't matter because the symptomatic hemorrhage is also not increased and overall outcome has become not been influenced by the presence or absence of antiplatelet agents. And this led to again an editorial by the same group of people who actually did the first study from the Netherlands. They now said that it is not only that these people are not actually faring worse in terms of the MRS, but they also showed that probably they are doing a better because they did an analysis of certain studies like this one from the Sakar et al. Who find that the persistence of arterial occlusion may be associated with symptomatic ICH. And because these patients were receiving the antiplatelet beforehand, probably there the thrombolysis was producing much better effect of this occlusion than the other group. So they said, they hypothesized that they cannot, should this patient be also deriving some additional benefit because of the use of antiplatelets prior to their thrombolysis. So they suggested some studies to test this hypothesis. I'll come to that later. So then there came this systematic review and meta-analysis of 19 studies in 2016. And again, you can see the diamond, although not very shifted to a great extent, but it still favors the group with the antiplatelet therapy. And there were a lot of studies included in that, and 19 studies in fact. And therefore, there was a reasonable amount of data to show that people who are receiving antiplatelet therapy, they can receive intravenous thrombolysis safely without losing out on their outcome at the 3 months at least. Then recently in 2016, this came with that risk and benefits associated with pre-stroke antiplatelet therapy among patients with acute ischemic stroke treated with TPA. And they included a large number of, this is based on a data search of a GWTG stroke registry. And they had a large number of patients, about 1,13,000 plus patients. And out of that, 85,000 had a pre-admission antiplatelet therapy. Out of that, about 38,000 had this antiplatelet therapy group, and 46,000, so large cohort. 28,000 were excluded. So what they showed that patients in the antiplatelet group were taking antiplatelet within 7 days before hospital arrival. Antiplatelet use were aspirin, clopidogrel, pasugrel, ticagrelor, or combination of aspirin, dipyridamole, or aspirin, clopidogrel. And primary endpoints were symptomatic ICH, in-hospital mortality, discharge ambulatory status, and modified ranking scale. And what they found out that between the two groups, again, it is very interesting to note that people who are actually using these antiplatelets are having much more atherosclerotic risk associations. They are actually much more prone to such events because you can see the prevalence of diabetes, hypertension, dyslipidemia. They were more smokers. They were more on statins. So all these factors were there in the patients with the antiplatelet group. And despite this, we could see that in terms of the SIH was definitely higher in this group as was demonstrated earlier, but the in-hospital mortality, independent ambulation, and the MRS score, they were all not very significantly affected. So if you see the forest plot here, you can see that the distribution of the drugs being taken. There were people who were only on aspirin, there were people who were aspirin and dipyridamole, and then there were people with a combination of aspirin and clopidogrel. And they have shown that within this group there is a dichotomy. There might be changes within this group, so we have to study these groups in separate and then come out to a possible outcome analysis. And they concluded that the use of intravenous TPA in patients receiving antiplatelet therapy was associated with slight increased risk of SIH, especially among patients receiving aspirin or dual antiplatelet therapy. So dual antiplatelet therapy was actually posing some increased risk. However, this relatively small excess risk did not translate in higher mortality and appeared to be associated with favorable functional outcome at discharge.